Thank you, dear Chairman. Thank you, dear colleagues, for your attendance. Today's topic will be systemic toxicity of local anesthesia. We have two basic classes of local anesthetics, either esters or amides. We have to understand shortly the metabolism as it plays a certain role in systemic toxicity. Esters are metabolized by plasma cholinesterase or serum cholinesterase or pseudocholinesterase, and so deficiency of this enzyme genetically leads to slower metabolism of esters, while amides are metabolized in the liver by the microsomal enzyme P550. There are certain conditions that lead to slower metabolism of amides. amides بالنسبة لدكاترة الرمد الحاضرين زي اللي بنستخدمهم كل يوم، زي الزيلوكين وزي الماركين وزي الأدوية اللي انتوا بتستخدموها، وهي دي الأدوية الامايدز، هي دي الأدوية اللي بتستخدم في مصر. الايسترز مش موجودة كتير يعني، انما انا بس عايز اطمن الناس حاطه سمعاني، احنا على تشانل 4، في ناس بس لسه جايه معلش عايزين ثواني معلش. Okay, there are certain conditions that may lead to slower metabolism. Any disease of the liver dysfunction, liver cirrhosis, congestive heart failure may delay metabolism, and drugs that are metabolized by enzyme, microsomal enzyme P550, like H2 blockers, may prolong the metabolism of amides. In general, amides are metabolized slower than esters, but the rate of metabolism is different between each drug. The fastest drug to be metabolized is prilocaine, followed by lidocaine, mepivacaine, ropivacaine, and the last one that show slow metabolism is bupivacaine. bupivacaine ده اللي هو الماركين، والليدوكين دايما واحنا بنتكلم كده الليدوكين هو الزيلوكين والبيوبيفاكين هو الماركين. Toxicity of local anesthesia. We have two categories, either local toxicity or systemic toxicity. Local toxicity in the site of injection is in the form of ischemic necrosis or direct neurotoxicity, while systemic toxicity in two forms also, either hypersensitivity or due to systemic absorption and higher plasma levels of drugs. Let us speak about local toxicity at the site of injection. We may have ischemic necrosis. This depends on tension from large volumes and the use of vasopressors. The use of adrenaline in such situation may lead to ischemic necrosis, especially in fingers or ear pinna, and sometimes in ophthalmic anesthesia also. We have direct neurotoxicity at the site of the injection. Lidocaine, اللي هو الزيلوكين, is more neurotoxic than other drugs, but when used in high concentrations, 2.5 to 5%. طيب احنا امتى بنستخدم ال 2.5 to 5%؟ الزيلوكين اللي موجود عندنا اللي احنا بنشتغل بيه هو 2%. 2.5 ل 5% ده used كان في السباينال انستيزيا، كان بيشتغلوا بيه زمان في السباينال انستيزيا. ليدوكين 5%. ايه اللي حصل من ليدوكين 5%؟ It can lead to transient radicular irritation syndrome. This is a self-limiting agonizing disorder affecting the lower limb and the buttocks. بيحصل فيهم pain و numbness after spinal anesthesia with lidocaine. هو self-limiting وعشان كده وبيرجع، يعني لو العيان شكى نبقى عارفين ان العيان الموضوع ده reversible مش permanent. برضو في reports حصلت of coda equina when lidocaine اللي هو الزيلوكين is used in continuous spinal anesthesia. كان في كاتيجوري اسمه continuous spinal anesthesia بنحط كاستر جوه سب اركنويد سبيس. في اوائل التسعينات الاف دي اي لغت التكنيك علشان جاء كذا ريبورت اوف كودا اكواينا. اكتشفوا بعد كده ان الكودا اكواينا از ديو تو حاجتين، الليدوكين نفسه، فبطلوا الليدوكين. الليدوكين 2% ده لو عملنا ريبيتد انجكشن على السيم روت هيؤدي في الاخر لدايركت نيورو توكسيستي. عملوا ايه تاني؟ غيروا الكاسيتر، خلوها بدل ما هي سنجل بور مالتي بور علشان الدراج يبقى ديستريبيوتد على كل الروتس، ما يبقاش على روت واحد ويعمل كودا اكواين. دكتور محمد انت سامع من غير سماعه؟ ها؟ طيب طيب let us speak about systemic toxicity which is the main issue. We have hypersensitivity in the form of urticarial rash, redness, angioneurotic edema. اسمع أحسن. Angioneurotic edema. But hypersensitivity reaction is rare. However, esters are more likely because they are allergens to para-amino benzoic acids, while in amides, allergy may be due to preservatives. Allergy due to amides is very rare, but still present. Systemic absorption lead to higher plasma levels. Higher plasma levels will lead to systemic toxicity. This systemic toxicity depends on site of injection, the rate of vascular absorption of the local anesthetic is higher in intercostal and paravertebral techniques, followed by caudal, followed by epidural, and lastly brachial plexus. أكتر سايت بيحصل منه vascular absorption ويروح للسيستميك هو الانتركوستال والبارافرتبرال. As regards retrobulbar block in ophthalmology, we have subarachnoid spread and brainstem anesthesia in the form of deterioration of level of consciousness and apnea. Another factor is the volume and dose. Use of high volumes as in bilateral tap block, peripheral blocks with large volumes and local intravenous anesthesia may lead or may predispose to systemic toxicity. In adverent intravascular injection, if we don't aspirate and inject intravascularly, it is a very important factor in systemic toxicity. Additives, especially adrenaline. Adrenaline delay absorption and has a lower incidence of systemic toxicity if adrenaline is added to local anesthesia. What are patients who are vulnerable to systemic toxicity? The diminuted patient, the small patient with small muscle mass. This patient, as muscle, is considered depot for systemically absorbed local anesthetics. So you have no مستودع أو store للlocal anesthetics فبتفضل في السيستميك circulation كتير. يعني العيان الضخم اللي جاي ده الانسيدنس of systemic toxicity أقل من العيان القليل. Extremes of age in children overdosage is likely, and small muscle mass also. And in elderly, we have the small muscle mass and organ dysfunction. What are other patients vulnerable to systemic toxicity? Patients with pre-existing cardiac disease, a severe valve disease and heart failure, they are more prone to myocardial depressions and arrhythmia. Renal and liver dysfunction. We have decreased metabolism and decreased clearance of the drugs. They stay in the circulation and cause systemic toxicity. And lastly, lipophilicity of the drug. The more the drug is lipophilic, the more is its toxicity, like bupivacaine, which is Marcaine. What are signs and symptoms of systemic toxicity? Systemic toxicity affects three systems: neurological, cardiovascular, and respiratory. The earliest signs are neurological. The first signs are circumoral numbness, tinnitus, dizziness, and slurred speech. العيان بيقول أنا وشي منمل، بيقول أنا حاسس بوشي في وداني، أنا حاسس إن أنا طالع في طيارة، followed soon by tremors, twitching, tonic-clonic convulsions. Soon, within seconds, بيبتدي المرحلة الثانية. طيب, local anesthetics are depressive to all systems, neurological, cardiovascular, and respiratory. Why here irritation and convulsions? Due to inhibition of inhibitory impulses within the CNS limbic system. Inhibition to inhibition, so excitation, but it is inhibitory. After convulsions, we will find CNS depression in the form of drowsiness and respiratory depression. Toxicity may be confined to the neurological findings only, but it can proceed dangerously to cardiovascular depression with hypotension and bradycardia and cardiac arrhythmia. Typical toxicity starts within 1 minute of injection, but we have reports of delayed toxicity, delayed to 1 hour and more, and it is only cardiovascular. The patient developed hypotension after 1 hour of injection, which is delayed systemic toxicity to local anesthesia. We have after 1 minute or delayed. Bupivacaine is famous for its myocardial toxicity. It causes myocardial depression, hypotension, severe ventricular arrhythmia, and even cardiac arrest. Why bupivacaine? Why bupivacaine is famous? It is more lipophilic, increased risk of systemic toxicity. All local anesthetics in the myocardium block the sodium channels during systole and dissociate from sodium channels during diastole. But Marcaine or bupivacaine dissociate from sodium channels much more slowly during diastole, so it causes cardiac toxicity. Strangely, there is central effect of bupivacaine. They inject experimentally small doses or in the medulla, and they find malignant ventricular arrhythmia from just small volume of injection of bupivacaine in the medulla. So this is the cause why bupivacaine. Lastly, we will speak about management of systemic toxicity. Systemic toxicity with a stable hemodynamic, just neurological, just convulsions, we used anticonvulsive. Start by benzodiazepine. If it is not effective, please thiopental or propofol in small doses. We can't use large doses, as large doses are respiratory depressant and cardiovascular depressants. So just small doses is very effective in prevention of, in treatment of convulsions. Respiratory depression, proper oxygenation, support of airways, jaw thrust, just controlled respiration with bag and mask, and in severe cases, intubation. If toxicity proceeds to cardiovascular system and we get cardiovascular collapse, we have to give fluids. Vasopressors start by ephedrine and then shift to noradrenaline, and inotropics, we use dobutamine or adrenaline from the start, and atropine if there is bradycardia. We will proceed to category which is called resistant collapse. and arrhythmia, resistant to conventional therapy, resistance to fluids and vasopressors. Here we should, ده مش احنا قطعوا علينا دخل في حتة تاني خلاص. We should start intravenous lipid preparation in severe ventricular arrhythmia. Please remember that we should give amiodarone only. We don't use lidocaine, as the cause of arrhythmia here is local anesthesia. So don't use lidocaine to treat ventricular arrhythmia. Use only amiodarone. And of course, lipid preparation. And in cardiac arrest, CPR, cardiac arrest in case of bupivacaine toxicity, is resistant to treatment. And you should use with CPR lipid preparation. Intravenous lipid preparation, we use intralipid 20%, 1.5 milliliter per kilogram over 1 minute, followed by 0.25 milligram, 0.25 milli per kilogram per minute. If there is resistance to treatment, we can increase bolus up to حاضر فاضل لنا دقيقة bolus up to 10 milligram. The mechanism here is lipid shuttle. The intralipid takes the molecule of local anesthetics and across the blood to areas of detoxification. Let us conclude. Conclusion. Toxicity of local anesthesia may be local or systemic. Local toxicity is either vascular necrosis or neurotoxicity. Systemic toxicity is either due to hypersensitivity or systemic absorption. Systemic toxicity depends on the site of injection, volume, accidental intravascular injection, low muscle mass, lipophilicity, or comorbidity. Signs and symptoms are neurological, respiratory, and cardiovascular. The early signs are neurological. Management depends on system affected. In case of severe arrhythmia or resistant hypotension or cardiac arrest, add to your treatment lipid preparation. Thank you.